A very good afternoon, everyone. I am Dr. Meena Putturaj. I welcome you all to this first virtual roadshow on public-private TB care service delivery models in India, where we will be showcasing successful models on engaging private healthcare providers in end TB programs. On account of World TB Day, this virtual roadshow is organized by TBPPM Learning Network India Chapter, Institute of Public Health, Bengaluru. IPH Bengaluru is the secretariat for the TBPPM Learning Network India Chapter. Before we begin, I would like to give some announcements. This is a 90-minute session. Please use the chat box for any questions or to share any reflections and thoughts. This session is being recorded and it will be live streamed in the YouTube channel as well. The link is provided in the chat box. We will be sharing your news post following the roadshow on our website. Please look out for any social media messages from Institute of Public Health, Bengaluru. If you want to know more about the other knowledge events organized by TBPPM Learning Network, please join our TBPPM Learning Network India chapter. Please write to us at tbppm@iphindia.org. I would now like to introduce Dr. Ramya Ananthakrishnan, who is the chairperson of the TBPPM Learning Network India chapter. Dr. Ramya Ananthakrishnan has nearly 20 years of experience in designing and executing public health programs. She is a medical doctor with a PG degree in community medicine. She has worked in National Institute for Research in Tuberculosis and also has over 5 years of teaching experience in medical colleges. She has been involved in strategizing, implementing, and managing several projects on TB, which is supported by organizations such as Global Fund, KNCV, TB Reach, Stop TB Partnership, USAID, etc. She is also leading the private sector engagement component under the flagship program of TB Free Chennai. She has been a facilitator for the union's operational research training courses. She has several scientific publications to her credit and has represented several international and national expert forums on TB. She is also a member of the National Technical Working Group on Private Sector Engagement. We are very happy to have you with us, Dr. Ramya. Over to you. Please give us the welcome note to the audience. Thank you.
Thank you, Dr. Meena. A very warm welcome to all of you who have joined us for this roadshow, the very first roadshow by the TBPPM Learning Network India chapter hosted by Institute of Public Health. On the occasion of World TB Day, it gives us great pleasure in rolling out this roadshow. And I think it's a tremendous experience for the TBPPM Learning Network India to host this webinar series. And we have a very a fantastic panel of experts both who are well-versed both in program setting and in private sector setting to talk us through the next 1 hour or so on their experiences. I think whenever we talk about private sector engagement and PPM, I feel PPM is a marriage of three things. One is the patient choice. Second is the quality of TB care services. And third is the private and the public sector coming together in a partnership which is facilitatory to both. So I think in this context, it is very important to understand that as we strive towards NTB targets, it becomes very, very critical to engage the private sector in a way and means in which they can participate. And we really need to understand what private sector needs are. And we need to have programs which cater to them. And that is where the whole TBPPM learning network initiative is all about, finding what the needs are from the private sector, what is the expectation of the public sector, and trying to bridge the gap between the two. So this roadshow is a tremendous opportunity for us in terms of showcasing the very successful models by the various organizations. And we really look forward to a fantastic 90 minutes presentation by all the experts in the group. Thank you very much and all the very best, and congratulations to Institute of Public Health for their new role of the Secretariat for the TBPPM Learning Network in India. Thank you, and over to Dr. Meena.
Thank you, Dr. Ramya, for that energizing note. Now it's time to showcase the PPM models for TB service delivery. So there are altogether 4 presentations. First, we will have 2 presentations followed by a Q&A session. And after that, we will have the remaining presentations, and again, we will have a Q&A session. So I now would like to invite Dr. Akshi. Dr. Akshi Kalra is a medical officer with Find India, where she plays a pivotal role in spearheading multiple projects on tuberculosis and NCD. She has worked with many organizations such as PATH, Institute of Economic Growth, and AIMS, where she has contributed significantly to various research endeavors. Her commitment to global health has earned her the prestigious President Volunteer Service Awards in the United States. She has many publications to her credit in peer-reviewed journals and books. Thank you for joining us, Dr. Akshi, today. Over to you, Dr. Akshi. The floor is yours.
Thank you so much. So, at the outset, I would like to convey sincere thanks to the TBPPM Learning Network India for this opportunity to kind of share our learnings with the larger audience and with the other experts from the TBPPM space. This has been one of our flagship projects that Find India had the opportunity to implement, which primarily focused on pediatric TB. And the idea was to improve the access to lab-based diagnosis for children with TB. So I think, as most of you agree with me, that the burden of childhood TB is not really well understood. It kind of has challenges in terms of the non-specific symptoms, which is then further compounded by the difficulty in obtaining a quality specimen in terms of use of the sensitive tools. Like right now, we just have microscopy, and then later on, when this project was implemented, then we had also we had about the GEAT expert, and then later leaving least scope, especially when we use only microscopy or X-rays for rift resistance diagnosis. And also a large number of children at the time when the project was implemented were focusing and getting care in the private sector, focusing mostly where we have the challenge of the non-standardized care. So the diagnosis was mostly kind of dedicated towards the level of having history of contact with a TB patient, the chest X-ray, or having just the Mondews test available, leading to the diagnosis. And as I mentioned, leaving hardly any room for diagnosis of drug resistance. So, basis this background, Find India envisaged a project under guidance from NTEP and the USAID under the Challenge TB grant. This project was launched in the 4 cities first: Delhi, Chennai, Hyderabad, and Kolkata. And subsequently, basis the learning from this project, it was extended to additional 6 cities, which is Vishakhapatnam, Surat, Bangalore, Nagpur, Guwahati, and Indore. This project covered around approximately 60 million population, and this was implemented for about 4 years. So the project had multi-pronged approach, and it followed a hub and spoke model. So the idea was that we are able to provide a free of cost gene expert testing to all presumptive children through high throughput expert labs which were established within the NTP diagnostic network. We were also trying to map the providers both in public and private sector so as to see that the number of providers who actually cater to the children or the child population. Provider engagement activities were undertaken in terms of one-to-one visits, trainings on sample collection, live demonstrations, as well as hands-on training with additional support through the CMEs. And a rapid sample transportation and results reporting linkages were created between the public and private sector, both in terms of the facilities from the decentralized peripheral facilities to the tertiary facilities or secondary facilities, depending on the type of sample to be collected, as well as with the labs for testing. And then the ones who were diagnosed, the children, they were promptly then linked to treatment for early initiation. When it comes to the provider engagement under the project, the activities focused on provider mapping. It went from web search to the list that was obtained from IAP, moving from the on-ground mapping, snowballing, just dial. So we tried to kind of have a holistic or a comprehensive list through multiple sources that were available with us. And we also received from NTP a unit-wise coverage, both for the formal sector and whatever the already mapped facilities were there in the informal sector. In addition, the advocacy efforts focused on sensitization meetings, CMEs, trainings on obtaining the samples. Along with that, very specific project-specific IEC or leaflets were developed, which are focused specific to pediatric population. I think in multiple times we hear that sometimes children are actually not the miniature adults. They have to be treated differently. Their diagnosis varies in terms of the requirements, and accordingly, these leaflets or IEC material were created. Along with that, one-to-one meetings with hospitals, clinics, and telephonic sensitizations were done. In total, about 1,416 facilities could be engaged. And along with that, the project also ensured there's a feedback mechanism or a loop mechanism where the provider could receive a feedback of the list of the patients that they had referred. Along with that, there is a feedback for the diagnosed cases. And there is a feedback for us to know which provider and how to categorize them basis their the load or the number of patients that they are seeing. So some of our learnings or understanding from the project, if you see here, about 60% of the link providers are actually from the private sector. And there is an incremental uptick, which we can see over quarter-wise from the beginning April 2014 to last quarter that we had reached. There was a consistent increase in the number of providers from the public and private sector. And especially when I say engage, it's basically at least one person sample was collected and referred to the public sector lab for diagnosis. The most important learning for us was even going beyond is that there is a commitment to actually diagnose through collection of non-expectorated samples. So if you see here, this is a largest cohort, like we are talking about 0.1 million samples collected. And of this, about 50,000 are sputum or induced sputum. And here about another 50,000, which is basically focusing on non-expectorated samples, like sputum samples, like gastric acid lavage. We have CSF, pleural fluid, bronchoalveolar lavage. We also have pus, lymph node, ascitic fluid, and others, including smaller numbers. Though we learned that about 50% were non-sputum, and as I will show you in a subsequent slide, in terms of the output or yield in terms of positive cases, was something very interesting that we got to know at that point of time, which is something that we would have been missing. An average turnaround time from the collection to the reporting was about 1 day. And for us, one of the key facets for the providers, especially in the private sector, was that 94% of the results were reported within 24 hours of sample receipt at the lab. So this is something that I was referring to. We kind of had put the samples both for expert testing, gene expert, and as well as for the smear positive results. Interestingly, when the samples were put on testing, pus or the lymph node aspirate samples had a positivity ranging between 30 to 35%. So it basically means like 1/3 of the samples sent for testing were actually positive. And importantly, we also saw that about 50% of the RIF resistance was actually diagnosed from the non-expectorated sputum, that is beyond induced sputum and expectorated sputum. This was something would have been really missed if these samples were not collected and sent to gene expert, because usually the reliance is on sputum, or if a sputum is not produced, people are generally relying on X-rays and probably the Montus test till date. And in overall, if we compare between the expert and the microscopy, there was a 3 times increase in terms of detection rate from 2% to 6.8% for the total number of samples. The key findings overall, so for about 94,415 children, we had about positive of about 6.6% were positive, 6,270. This is coming from about cohort of 1,416 individuals or providers, and they led to an increase of about 3-fold in the case detection, especially microbiological confirmation that is being referred here, which led to a better or an early diagnosis as well as the treatment initiation. It also facilitated a turnaround time of about just 1 day, that is, including from specimen collection, transportation, testing, and including reporting. Along with that, what we additionally found was a 9% of the rift resistance cases from these diagnostics, which could have been possible because of the testing through the microbiological confirmation moving beyond from microscopy and chest X-ray. And 89% of these children were linked to treatment. There were also, as I think for any project, there are also talking about the key challenges. So we did have a few challenges, and there were also mitigation plans because that becomes very important to be able to see or focus how do we manage that. So there was lack of facilities who could collect the ET samples, or I would rather also include gastric aspirate sample collection, even induced sputum. There was a hesitancy because these are slightly invasive in nature, not literally in terms of but this not in terms of like expected sputum, which basically doesn't require any kind of active intervention. So there was slight hesitation, which we realized, but we tried to link these facilities at the secondary and the tertiary with the tertiary level facilities where sample extraction facilities were available. And we also kind of started an initiative, which is being now scaled up under a TIFA grant, where we are trying to do is that we are trying to centralize the sample collection at the CHC or the community health centers. So the medical officers and nurses could be able to take up the collection. There were also competing interests, especially in the private sector labs where the providers were sending samples. So we tried to link them with the IPAC labs, where there's a standardized subsidized rate agreed for gene expert testing. And there was a slight perception already built for the public sector. Delays, talking about the confidentiality, talking about in terms of loss of patient, which were all kind of discussed and mitigated in discussion with the providers through one-to-one meetings, and also kind of the rapport building which happened over a period of time. It led to a sustenance that the provider still send the beneficiary or the household or the patient and then ensure that their sample is getting tested and then the result is reported back. There were also a few key factors for success. One was a detailed mapping, where we involved a holistic approach of reaching out to different sources, as I mentioned earlier. There were also city-specific handouts and flyers design, which was very crucial, especially these were translated into vernacular languages to ensure a maximum reach. There was intensive engagement with the identified providers as well, like for CMEs, outreach camps, one-to-one interactions. We also ensured there was a zero incidence of cartridge stockout or machine downtime. So Find was actively working in terms of for the diagnostic part, ensuring that this component is not something that there is any question on the testing part. There were training videos developed for the EP sample collection as well as for the induced sputum and gastric aspirate. And these have been posted on the National TB program website. And also we were ensuring that there is a notification given to the government as part of the NICSHE so that there is no delay in the reporting. So just to summarize, before I share the last learning, this was one of the first initiative in the country with upfront access to the gene export, focusing on the PPM activities, largest pediatric cohort evaluated, and it led to policy decision by the National TB program, which mandated the upfront gene expert testing for TB diagnosis among children. It has been cited in the WHO document as one of the best practices, as well as featured in the SDG impact story. There were also sample collection videos, that is induced sputum, gastric aspirate, and FNA. And along with that, currently we're working on developing for CSF as well, which have been hosted on the NTP website. And it also led to increase in the bacteriological confirmation I just shared, like 9% drift resistant cases, which could have been missed earlier. These are few publications. Would be happy to share the links separately if anyone requires. There were about 10 publications from this entire activity that was undertaken along with the WHO communication as well as the SDG website. I'm not audible.
You are audible. We can hear
Oh,
you.
I'm audible? Okay,
Yes.
okay. Yeah, and this is the screenshot of the videos. If anyone would like to go and explore, these have been put for the 4 things like GA, tuberculin skin test, induced sputum, as well as for fine needle lymph node aspirate. Thank you.
Thank you, Dr. Akshay, for presenting the model which is based on using gene expert testing for the diagnosis of TB in pediatric population. Thank you so much. So if you have any questions related to this particular model, please write your questions in the chat box. We'll take it up later for discussion. Next, I request Dr. Arsha from the organization PSI to do the presentation on e-pharmacy model. Dr. Arsha is with PSI. She has a specialization in health administration and BDS and advanced certification in health financing. She's a result oriented public health professional with over 12 years of experience. Dr. Harsha has a keen interest in using technology and has worked with various innovators for conceptualization and demonstration of about 30 innovations for systems strengthening, private sector engagement, and demand side interventions within urban and rural public health systems. We are very happy to have you with us today, Dr. Arsha. Please present us your model, e-pharmacy model, to the participants. Thank you.
Hi, good afternoon, everyone. And I'm here to present on one of the public-private partnership initiative to ensure doorstep delivery of services for persons with TB in Indore under Project Samagra. So in my presentation, I'm going to briefly talk about Samagra, what the project is, what are we focusing on, um, where are we working, and who are our partners in this initiative, followed by a detailed discussion on the doorstep service innovation, in terms of the design, the process flow results, and what is the next step that we're looking at, under this innovations. Talking about Samagra, Samagra is a PSI-led USAID-funded initiative focusing on urban health. And we're responsible for working on the recommendations of 15th Finance Commission and Pradhan Mantri Ayushman Bharat Health Infrastructure Mission, which is PM-ABHIM, to operationalize health and wellness centers in the intervention geographies, focusing on the urban, India. Apart from focusing on government efforts and complementing them, we are also testing out innovations to reduce out of pocket expenditure on health, uh, mostly through insurance and addressing social determinants of health by enabling access to social entitlements. In terms of our strategic objectives, we are here to catalyze community engagement, strengthen capacity and efficiencies within health systems, and ensure affordable and accessible health services for the urban poor. We have a total market approach where we are working with the government and bringing in private sector as and when required to complement government efforts or address those gaps which are not being addressed currently or by the government themselves. We present in 5 states right now: Madhya Pradesh, Maharashtra, Telangana, Jharkhand, and Odisha. In these 12 cities, and apart from the central government and state level partnerships with the government health department, we are bringing in private sector expertise through PATH, Uplift Mutuals, Visit, Entitled, and Haqdarshak. Now, coming to the doorstep delivery innovation that we've been working on, some of you might know that under Shops Plus, doorstep drug delivery for persons with TB was already tested during the pandemic. So in 2020, when patients were scared to move out of their houses and the treatment compliance was compromised, PSI under Shops Plus, which was again a USAID funded project, had enabled doorstep delivery of drugs. So to ensure that there was continuity of treatment and people did not have to walk out of their houses to to kind of get medication. Now, as next steps under Samagra, we were asked to expand these services beyond drug delivery to include diagnostics, and secondly, to also understand the barriers that persons with TB as well as other comorbidities, including diabetes and hypertension, face. So we conducted an ethnographic study, interviewed 500 TB patients, and documented user journeys particularly in the urban context, for patients who are seeking care from the public sector. What we found out was, though the TB services and treatment is completely free in the country, more than 93% of these patients had to travel up to 10 kilometers to access the free services. Every second patient that we interviewed shared that they had to face a wage loss of approximately 300 rupees per day, while one fourth of them experienced more substantial wage loss ranging between 500 to 1000 rupees per day. Based on these findings, we hypothesized that this economic impact could potentially be a contributing factor to low treatment adherence and ultimately leading to poor treatment outcomes. We also, like I said, we also documented user journeys. In user journeys, we classified the TB patients into three archetypes: dependents, confidentiality seekers, and the victims of mistreatment. Um, Based on our interaction with with patients and our observations, we concluded that patients who had some sort of dependency, either due to disability or mobility challenges, were keen to accept doorstep delivery of drugs and diagnostics. However, patients who sought confidentiality or were previously, victims of mistreatment, did not want to risk anything, and they wanted to go to the health facility and seek treatment themselves. Now, under Samagra, what we did was we worked with the district TB department and brought in a private health partner, which is Visit Health, to design a doorstep service delivery pilot for patients with TB in Indore, focusing, covering of Indore, all 13 TB units by the National Tuberculosis. How about the role of the private sector partner in this initiative? Um, so we digitized the algorithm and seamlessly integrated it with the hyperlocal distribution network. Simultaneously, we built capacity of the local private sector partner on sputum collection and drug delivery. Apart from digitizing the algorithm and creating a hyperlocal distribution network and building the capacity, we also introduced interactive elements of telecounseling and WhatsApp reminders to ensure treatment compliance. In terms of process flow, so we would get data from the TB department. From Am I audible?
Yes, you are audible.
Okay. Yeah. Um, so we would get data from the district TV department based on the which essentially was Nikshay, from Nikshay portal, wherein the patients were already sensitized on a private partner coming in asking for doorstep, asking for their consent to provide doorstep services, both for drugs and diagnostics. Then, based on the data that we received, we mapped the health facilities, TB units, and public health facilities for those patients. And then, after a telephonic consent, we enrolled these patients into our intervention. The system would automatically schedule deliveries and sputum collection based on the date of last refill, as well as the treatment phase they were in. We were specifically dealing with drug sensitive TB, so the sample collection only happened at the end of IP and CP, so at the end of second month and the sixth month. We also inbuilt reminders and push calls and pre-scheduled calls to ensure treatment compliance, and also to ensure that the patient is available at their place to collect medicines, as per the scheduled delivery. In terms of public-private coordination, while right after scheduling and sending reminders and getting confirmation from the patient that they're available to take the medicine or provide sputum sample, a notification would be sent to the associated TB unit to get the to keep the drug package ready, as well as the sputum cup ready, and then the system would automatically assign job to the nearest delivery agent to kind of sample pick up, as well as drop it back to the health facility. On the day of the delivery, what would ideally happen is the delivery agent would deliver the medicine and collect sputum cup and give it back to the health facility where the testing had to happen. This was followed by a confirmation from the patient that they've received the delivery of drug, they've provided sputum sample, and they were happy with the service of the delivery agent. This is a small video to quickly showcase the whole system of registering a new patient, enrolling a new patient, and assigning, scheduling deliveries, and assigning delivery agent for the task. In terms of results, we reached out to 1,966 patients and serviced them with both sputum sample pickup as well as drugs delivery at their doorstep for over a period of 5 months on an average. And more women, approximately 52% of our patients were women who were serviced through this model, and we saw a treatment completion rate of approximately 89%. While our initial assumption when we started testing out this model was that elderly people and people with mobility challenges would be more keen in accepting doorstep delivery of services, what we found out was, you know, elderly people saw this as an opportunity to walk out of their houses and go to health facility, especially in the urban context where social networks have shrunk, and you know while more adults in the age group of 18 to 45 years, 70, which is approximately 75% of our patients who were serviced, belong to the age group of 18 to 45 years, who were either employed in gig work, or had schools to attend, colleges to attend. They're more keen on getting the services at their doorstep, so that they do not have to skip work or suffer wage loss. uh, During the intervention period, which was 9 months, we serviced 87% of the listed TB patients in urban Indore. Here's a small video from the patients uh, providing feedback. मैं वर्षा मंडलम और मुझे टीबी हुआ था
तो मुझे टीबी होने के बाद 2-3 महीने मैंने हॉस्पिटल से दवाइयाँ ली थी। उसके बाद मुझे हेल्प मिली लाल हॉस्पिटल से समग्र नाम का जो है वहाँ से एक योजना निकली थी। उसके तहत मुझे गोलियाँ देने आते थे और मुझे उससे गोली मतलब वो मुझे देकर जाते थे। वो 4 मंथ तक कंटिन्यू गोली आती रही, मुझे जाना नहीं पड़ा बाहर कहीं भी और इससे मुझे काफी हेल्प मिली। प्रोग्राम से मुझे घर बैठे दवाई मिली जिससे मुझे फायदा हुआ। मुझे दवाई लेने नहीं जाना पड़ा, मेरा खर्चा बचा, मेरा काम धंधा भी नहीं छूटा और मुझे इससे बहुत फायदा हुआ। मैं चाहती हूँ कि ये सेवा हर इंसान को घर बैठे मिले।
Here are a few verbatims which have been translated in English, where patients have shared that this made them stick to their treatment. It was a big help in terms of saving time of travel and wage loss. This also helped them, get control of their own care, and they felt a sense of empowerment. There is a patient called Sonu Rajesh who shared that, you know because he lives alone, he was more keen on such services for extending beyond TB. In terms of way forward, what we're looking at right now is, under this initiative, we've learned about the barriers that are present for patients with TB, but also beyond TB, including comorbidities. During the user journeys that we documented, we've learned that there are several challenges, systemic challenges that exist while when we're talking about integrating TB services within the comprehensive healthcare service package and operationalizing TB care in the health and wellness centers. What we've sort of learned is there could be potentially a defined role for the private sector partners to provide in support in case of shocks and shutdowns like the one that happened during the pandemic. And this service model could actually be extended beyond TB to include diabetes and hypertension, and where consistent treatment compliance is required. And there, being in the urban geographies, there are challenges which are, both in terms of wage loss and the accessibility barriers could be reduced through models like these. That's all. I would like to thank IIPH for this opportunity, and the Learning Network as well for this opportunity, to Samagra and PSI. And I look forward to your questions. Thank you.
Yeah. Thank you, Dr. Arsha, for presenting the e-pharmacy model and its importance for TB treatment adherence. We have completed 2 presentations now. Maybe it's time to have the first Q&A session. There are a few questions in the chat box. We will take those questions for discussion. I would request Mr. Vinod to please unmute your mic and ask your question. I would request you to keep your questions very short. In the interest of time, I'm asking this. Vinod, please pitch in.
Yeah, sure. To Dr. Akshi, first question was with Dr. Akshi.
Yes, please.
Yeah, Dr. Akshi, you in the model you provided the upfront gene expert to the pediatric patients. So I just want to know whether the CBNet machines of the program, NTP program, was used, or the additional machines were provided under the program.
Yes, so we had utilized the existing machinery under the program, and but in the same time also we had provided at 3 districts we had to provide the gene expert machine where there was no availability in the vicinity of about 50 kilometers. This is something that we are talking about the period between 2014 to 2018, when the deployment had just initiated and it was being scaled up. So for the 10 districts, out of that, 3 we had provided.
Okay, and that gene expert was at the district level or in the periphery also?
So this was at the district level, and we had also kind of tried to create a hub and spoke model wherein the nearby facilities were linked so that there is less number of, I would say, less kilometers or less distance needs to be covered by the guardian or the sample transporter.
Thank you. Thank you so much.
Thank you.
Thank you, Akshi. There's another question in the chat box. from Aniket to again Dr. Akshi. He is asking, you have mentioned about non-sputum specimen collection. How was the response from the private sector for the collection of such samples? This is the question to you, Dr. Akshi.
Thank you. I think, yeah, this was a learning for us as well. In the initial period, there was slight resistance because this was something which was a time-taking process. Like it takes about 10 to 15 minutes if you're talking about the chest percussion, nebulization, and then induced sputum sample needs to be produced. So, but then when we kind of spoke about multiple times about the relevance that it adds in terms of the rip resistance that it brings out, also in terms of ensure the diagnosis is absolutely correct. There was a kind of shift in the provider behavior also that we observed during a period of time. And gradually we saw that out of 60% providers, like I mentioned, like 14, 16 were the total number of providers engaged, and 60% were private sector. We saw about more than 50, 60% have started to collect samples. It also had a component included, like for induced sputum or gastric aspirate, we need to have a facility where a patient could be, made to, if for GA, for example, a patient can have an overnight stay, or for induced sputum, there needs to be at least 4 to 5 hours of fasting. So that kind of infrastructure and facility was not even available at all the facilities, especially in the clinic level. Those providers who just see the patients in the OPD, there these facilities are not available. But for those who could, like had nursing home or had at least a indoor facility, or at least a person where he could be admitted for like 4 to 5 hours with 30 minutes post OP sample collection procedure, there we were able to bring in the change. And there was a slight reluctance to summarize, but yes, it worked out well overall. And as I mentioned, we are trying to scale this up right now as well under another initiative. We're working on a PIFA project. So there also we're trying to see how best we can decentralize both in public and private sector, considering that the non-speculated sputum samples still remain relevant for the pediatric population. Thank you.
Thank you, Dr. Akshi. One question for Dr. Arsha. And there is one more question to Dr. Arsha, but that we will take it a little later in the interest of time. Shruti, I see your question in the chat box. Would you like to come in and ask your question directly to Dr. Arsha? Please make it very brief.
Yeah, sure. Thank you. So the just question was like in Dr. Harsha's presentation, we could see that it was all urban setting, what she mentioned. So like since the program has one for every 2 lakh population in the urban setting, so I just wanted to understand if it was really urban or peri-urban where they felt the need of this career, or, as in like e-pharmacy system. And just to add on to that, one more thing was like regarding their results, like what is actually, as in preferred versus need, you saw like, of course, people prefer door delivery when you are given, but what was really the exact need in your cohort, what you saw? If you had seen that, you could throw light on that. Thank you so much.
Sure, I'll try and quickly respond. Yes, we were covering the peri-urban region as well in Indore. So we were covering all 85 wards and, peri-urban areas of Indore. The other important finding was that people, while they had assigned designated TB units and PHIs, they preferred to go to Lal Aspatal, which is the district TB office, which had all sorts of testing and the doctor consultations available, and they preferred to go to the Lal Aspatal, which was again far off, and hence they preferred for doorstep delivery of services, especially during the second, third, fourth, and fifth month. They wanted to go back to the health facility, consult the doctor at the end of the treatment, at the end of 6 months, and also, they had to go during the date of time of diagnosis and treatment initiation, followed by end of IP, the intensive phase. So that was our finding on the distance and the reason why people preferred this service.
Thank you, Dr. Arsha. There is one more question, burning question, I could say. Like usually there is a lot of stigma around TB, right? The people don't want to identify themselves as a TB, persons with TB and all that. So if
Right.
that is the case, how delivering TB drugs at the doorstep work? I mean, what was the response from the persons with TB and also their family members?
Absolutely. So like I said in my presentation, we documented user journeys and identified categorized TB patients into 3 categories. There was a subset of patients who were confidentiality seekers and did not want to share their disease status, while there was also a set of population who was more comfortable drugs being delivered at their doorstep. So patients who sought confidentiality did not want to participate in the intervention, uh, continue to seek services from the health facilities where they were doing. We particularly focused on patients who provided consent and were comfortable with this sort of service. In terms of addressing the stigma itself around TB, we were not the partner which was doing it, but there was another partner in Indore with the district TB department, which is focusing on behavior, social and behavior change, as well as also providing the prophylaxis treatment for the TB families.
Yeah, thank you so much. So we have now seen two exciting, innovative models to detect, one for detecting TB, the other one for treatment adherence in TB. Now we'll move on to the other presentations. I now request Dr. Smriti Riddhi to showcase the model on Stop TB Reach Wave 7 model. Dr. Smriti Riddhi is a faculty research associate in the Department of International Health at the Johns Hopkins Bloomberg School of Public Health. Her current work focuses on building the capacity of national public health institutes to effectively lead the response to global health security threats. She has worked in collaboration with national centers for disease controls across Africa, Eastern Europe, and the United States. During her time at Innovators in Health, she played a pivotal role in planning and executing private sector engagement in TB response in rural India. Thank you, Dr. Smriti, for joining us today. Over to you, Dr. Smriti. Please show us the model.
Thank you, Dr. Meena, for the introduction and also the opportunity to talk about our work here today. So today I'll be talking about a project that we implemented a few years back around engaging private practitioners in TB care. The grant was awarded by Stop TB Partnership, and I'll be talking on the behalf of the organization Innovators in Health. So I'll be covering the background and the objective of the project, the setting in which it was implemented, the project model, our learnings from the model, the kind of impact that we were able to create, some of the innovations that we included, as well as challenges that we encountered while implementing the project. And I believe the importance of engaging private practitioners has been highlighted on the stage multiple times. So I'll skip that part and move directly to what we did under our project. So giving a little bit of background about the organization, Innovators in Health is a grassroots nonprofit. It is working in rural Bihar since 2010 towards improving TB care. The mantra of the organization has been to stay in the community that it started working from. And in the process of delivering various programs that it's been awarded, develop models, tools, resources, blueprints for other organizations to follow, and it has successfully been able to deliver that. So in September of 2019, Stop TB Partnership awarded a grant to Innovators in Health, and the idea was to transform TB case finding, diagnostics, as well as care. The overall evaluation criteria of the project was case finding, but both the donor and the implementer had a very holistic approach to TB care. So we put an equal effort in improving the diagnostic practices, the treatment completion success, as well as the case finding. The program lasted for 15 months, so it ended sometime around the first quarter of 2021. The program also had one other wing attached to it that focused on empowering women and girls. I won't be talking about that today, but I felt just the need to highlight that that was also a very important part that improved TB care in the area. So as I already talked, Innovators in Health works in rural Bihar, and this is where this project was implemented as well. In rural Bihar, there's a district called Samastipur, and that was the intervention area. We included 8 rural blocks and 3 urban hubs as our intervention area, and as you can see on the map, it's highlighted on the map. So before I move on to what the project model looked like, I believe understanding how do people actually seek care for TB in this context is very important. So the model was very much was embedded in this understanding and also the experience of the organization that it gained over the past 10 years. So on the map, you will see three yellow dots. Those are the urban hubs where private practitioners are located, and people living in the nearby blocks, as well as some of the neighboring districts, generally travel to these urban hubs to visit a private practitioner, a formal private practitioner. And then after a treatment is done within a day, usually they have a day's worth of time. And after consulting the doctor, they move back to the block they came from. And they usually continue their treatment from their hometown. So with that understanding, we began developing the project model, and the first steps towards doing that was mapping, stakeholder mapping and engagement. We completed a mapping of all the providers, pharmacists, labs, and chemists in the intervention area. The mapping was a very hands-on process. We visited the whole locality, the three hubs that I talked about. We also received some historic data from other organizations who were working in the area previously, as well as the state and the district TB program. Once the mapping was complete, we charted a path of who to engage first, where to approach them, and things like that. After doing that planning, we started engagement with physician and physician assistants to develop a referral network in the urban hubs. And we also engaged ASHAs and rural medical practitioners within that referral network in the rural hubs. So for engagement, we kicked off the engagement by conducting some seminars or CMEs where we engaged the district TB officer to take the lead. In the CMEs, our primary aim was to introduce the project, discuss the expectations of the project, learn from physicians what is something that they find exciting about the project, and also some of the challenges that they expect that we would encounter moving forward. And that was essential in getting all the stakeholder input was very essential in how we planned our next steps. So once the mapping and engagement was conducted, the project started, and we began case finding through networks. In the physician's clinic, when we did presumptive TB screening. So when a person with TB symptoms walk into a physician's clinic, it could go either of the two ways. One would be the patient has symptoms, but the doctor thinks that just prescribing some medicines to alleviate the symptoms for a certain amount of time, and then they suggest the patient to come back for a follow-up. Or the second outcome that could be is that the doctor feels like the patient could have TB, and they suggest certain diagnostic tests, primarily chest X-rays, but through the program engagement, microbiological testing also became one of the priorities of physicians. So we followed up with both these patients. Oftentimes in private engagement models, program generally only works with people who are diagnosed within the day of TB, but we kept following with other people who had similar symptoms to TB but did not complete the whole diagnostic process. We followed up through ASHAs and phone calls to check how the symptoms progressed, if they got better, or if there's still an iota of chance that they might have tuberculosis. And then we encourage those patients to come back to the private practitioner's clinic and complete their diagnosis. So that is where that ended. So once a doctor thought that the patient might have tuberculosis and advised diagnostic testing, we supported sputum transportation to the CBNAT labs. We had one in-house CBNAT lab other than the government CBNAT lab. So that helped make the process very easy for us. We tried to generate the reports of all the gene expert testing within 24 to 48 hours. And as soon as the reports were generated, they were uploaded to an online Google Drive that the hub coordinators who were linked to various clinics had an access to, and they would efficiently relay that information to the doctor. In some of the places, we didn't have hub coordinators sitting with all the doctors. There were 2 to 3 hub coordinators covering around 20 practitioners in one area. So it was quite essential to engage physician assistants in all the operations, and they are not always tech savvy. So we also used WhatsApp to transmit that information about patient sputum findings. Once that was done, we also supported the patient with comorbidity testing and next-year enrollment. We supported HIV and diabetes testing, and they were enrolled for direct benefit transfer in the next-year portal. And the last step of the process was giving treatment adherence support to the patients. So as I talked about earlier, patients would move back to their home settings and would continue their treatment there. So we engaged ASHAs who were working in those particular blocks to follow up with the patients if they are taking their medicines on time, if they are sticking to the follow-up suggested by the doctor or not. Sometimes the patients would prefer sticking to the medicines that were advised by the doctor, and sometimes they would. Some doctors even preferred advising FDC medicines. So, in case an FDC was advised, we also did deliver drugs, but most of the drug delivery was done at the doctor's clinic, and the doctor would, the pharmacy that was within the doctor's clinic would give medicines to the patient. In the case when the patient is not willing to come for a follow-up after repeated counseling sessions, we in the interest of completing the treatment, we also sometimes deliver the drugs at the doorstep. So some of the insights that we gained from this whole process, I'll start by talking about physician engagement. And that is something like, that is one of the primary key aspects of running a private practitioners program for TB care. So it is critical to identify and build rapport with key physicians in your intervention area. When we did the mapping and also looked at the historic private notifications in their area, and after implementing the program for initial 2 to 3 months, we realized that although there are like 30 physicians practicing in a particular area, there are 2 to 3 who are contributing to almost 60% of the case finding. And having those 2 to 3 people on your side will not only be the path of released resistance, but also will motivate other providers to be engaged in the project. So it's very important to understand the motivation of those key physicians who are diagnosing most of the people. As per engagement, CMEs do serve as an excellent entry point, and I believe a lot of programs out there are dependent on CMEs for building the networks as well as also for continued engagement. But one other thing that we found useful as a project is that many prominent practitioners highly valued regular and periodic engagement other than CMEs. CMEs are also a bit cost intensive, so it was not possible to do that every month. So that was something that we reserved for once a year or maximum twice. So the periodic engagement with physicians included sharing valuable insights regarding their practice. So we used to collect a lot of patient data from the physician's clinic. So just the data around who came, who went out of the system, how many patients did actually come back for a follow-up, how the treatment outcomes look like, if the doctor diagnosed a patient on the basis of an X-ray, how their microbiological outcomes look like. And many of the doctors appreciated learning about this, and that gave us a point of maintaining constant contact with the physician and also acted as a value proposition that the program provided. Another engagement insight would be building relationship with physician assistants, also called as compounders, who are at the clinic. Having a workforce that covers every clinic in an area is not a very cost-effective measure, and oftentimes it's not possible with the kind of grant funding we receive. So people who are already available at the clinic and are already aware of ins and outs of the operations could be very helpful in running an important program. So building relationships with them to facilitate things like sputum collection, data collection for next share, as well as comorbidity testing was very useful for the project. DBT is another motivator we talk about, but oftentimes it is not on time. So when we entirely depend upon the DBT, that might become an issue for in continuing the engagement with physicians. So some of the insights that we gained from quality of care was efficient sputum transport network did improve DST diagnostic practices, as well as continuous supply of FDCs and timely DBT for patients also improved treatment completion rates. So coming to the impact of the project, the first impact I would talk about is building the network. The project was able to engage more than 100 providers, around 1,800 ASHAs within a period of 1 year. We saw that the private notifications jumped 47.5% within a period of 1 year in our intervention area. And this was despite of the pandemic. So 2020 was peak pandemic, and we could not implement everything that we thought of. Still, we saw a considerable increase in the private notifications. In diagnostics, the drug sensitivity testing improved from 11% in Q1 of 2020 to 68% in Q4 of 2020. We also covered 80% patients and conducted HIV and diabetes testing for them. We were able to successfully initiate treatment for 99% of the people. Out of them, around 82% successfully completed their treatment. Some of the innovative aspects that we included in the project is one, building a strong referral network that I have already touched upon, data sharing with the patient, with the doctors in real time. As soon as the reports are available, the doctor was made aware of it. So that is something through cloud or Google Drive. That was one of the innovative aspects of the project. We developed pre-framed forms to populate the Nixshare, and we developed QR codes to collect that kind of data to streamline the process, and also such that we don't burden the compounders that much with data collection. And finally, there was also a component where we used AI for screening X-rays during the COVID-19 pandemic. And in cases where patients were not able to visit the doctor, we did utilize teleconsultations. And moving on to the last slide, some of the challenges that we encountered during the project. Patients often have a non-linear pathway. They don't directly go to this practitioners and complete their whole treatment. They will first go to the PHC, then contact an RMP, and then visit the private practitioner for a second opinion, and then might move back to the previous pathway to complete the treatment. So having an following up with the patient, how the patient is moving was time consuming. Physician assistants, when we were implementing the project, there was no provision for incentives for them, and engaging them in a labor-intensive work was sometimes challenging in case of lack of incentives. There was also sometimes a conflict of interest between different stakeholders who were notifying private patients. We were engaging ASHAs and physicians, and there's a linked incentive to notify a patient. So oftentimes there was some conflict of interest, but we dealt with both point number 2 and 3 by building stronger relationships. And again, last 2 points are about patient follow-ups when they moved out of the intervention areas or when they didn't come for follow-up visits. So That was a very quick overview, but we have compiled a video where you can hear from everyone who was engaged in delivering the project. The video is uploaded on YouTube, and it will be very helpful in giving a full flavor of how the project implementation looked like. And please do reach out with any questions you might have. Thank you.
Thank you, Smriti, for the presentation and showing the importance of building relationships and engaging with the private sector for TB service delivery. We now move to the next presentation by Dr. Deepak. Dr. Deepak Balasubramanian is the Deputy Director TB for South Asia region at PATH. In his previous role as Vice President Public Health, he led the National TB Program, MIS, Nikshay development, and oversaw the build of Smart Payments Contract Management Digital Module. He also served as WHO National Consultant, TB Comorbidities in Ministry of Health and Family Welfare, Government of India. He played a critical role in the formulation of the guidance document on partnerships and expanding the public health action being provided to persons with TB in private sector. Welcome, Dr. Deepak. I now hand over the session to Dr. Deepak, who will be speaking about EPTB scheme, extrapulmonary TB scheme. Over to you, Dr. Deepak.
Yeah, good afternoon, everyone. Thank you, Dr. Meena, for the introductions. So at the outset, I'd like to thank the TBPPM Learning Network for giving PATH the opportunity to present on the EPTB partnership scheme from Mumbai. So PATH, for those of you who may not be aware, is a global organization that works to accelerate health equity through innovation and partnerships, and had rolled out the public-private interface agency pilot in Mumbai way back in 2014, and we continue to support the state of Maharashtra. So I want to take you through the journey of the EPTB scheme from the initial brainstorming to actual service delivery to the person with TB. So I'll be covering 6 components here, starting from the background, objectives, the scheme life cycle, learnings, challenges, and the way forward. And we'll be happy to hear any feedback or take queries at the end of the session. So while Mumbai accounts for around 0.2% of the land mass and 17% of the population of Maharashtra, it contributes about 1/3 of the TB burden in the state. So among the notified cases, a little less than half have exclusive extrapulmonary TB. So these patients require high-end investigations, which include ultrasonography, a CT-guided lymph node biopsy, pleural tapping, fine needle aspiration cytology, and histopathology, etc. for confirmation. So the issue in the city was that these investigations are available only in tertiary facilities such as medical colleges and selected peripheral hospitals in Mumbai. So which results in long waiting time for access to these investigations, or if they are present in the private sector, result in high out-of-pocket expenditure. So these barriers result in limited access to the services, promoting inequity, especially among the poor and marginalized populations. So what we intend to do with this scheme was to ensure universal access to all the specialized laboratory investigations, and it will be free of cost to the beneficiary and would be accessible at the nearest health facility. So as part of this process, we sort of supported the city TB office in formulating the partnership scheme. So we had around 8-step process as mentioned in the guidelines for partnership, which were followed. So initially the need identification was carried out, in which we had done an assessment of the EPTB burden across all the districts, and consultation by the city TB office with all the 24 district TB officers, physicians in the private sector, medical colleges, the medical officers, and other stakeholders, discuss strategies to improve access and reduce time taken for diagnosing people with EPTB. So based on the need assessment, a service scope was designed, so which was envisaged to provide a pool of funds to the city TB office to provide these services free of cost by engaging private sector institutions. And budgets were also formulated, following which a proposal had been submitted to the Municipal Corporation to obtain the administrative approvals, and a competitive process had to be done to empanel the private institutions. So approval from the municipal corporation had been received, following which that had been published on the e-procurement portal, as well as the newspapers in 3 local languages. And the DTOs, along with the NTP staff, disseminated information to all the concerned facilities to encourage their participation in the selection process. So there was a due diligence process following which around 18 applications were shortlisted, and negotiations were held with the expert panel, following which the rates for the different tests were also finalized. And following this, official communication had been sent from the CTTB office to all the 24 districts to implement this scheme. And we have also supported the linking of the districts with the empanel facilities. All the investigations regarding NAT testing subsequently were linked back to the existing NTP public sector gene expert sites. And persons with TB referral and linkages were referred through vouchers, which were printed and provided to all the laboratories and the other health facilities. So overall, the management here included the Mumbai Municipal Corporation, which was overall managing the scheme, while the NTP staff in the local level were responsible for the operational aspect. So PATH was providing technical support for all these processes. So with regard to the approvals, so this proposal was submitted within the annual action plan, and around 15.18 million, which is around 1.5 crores, or a little less than 190K USD was approved. And the municipal corporation has been verifying the invoices and making the payments every month. So some learnings which we had from the implementation was that the scheme journey demonstrated measures for streamlining the due diligence and the empanel process, and it showed potential for scheme formulations with technical assistance from different stakeholders. And lastly, the vouchers continue to remain effective for referring the presented beneficiaries and verifying the payment to the empaneled agencies. So we also had some challenges. So for the arriving at the market rates, several rounds of the negotiations had to be held. An expert panel had to be constituted to finalize the rates. Similarly, among the different applications received, we had to come up with eligibility criteria to define who would be eligible and ineligible to participate in the scheme. And thirdly, Mumbai has around 24 districts, among which only 13 districts had a facility. So the remaining 6 didn't have a facility available and had to be linked back to the 18 empaneled facilities. Lastly, there was also a need for timely payment to the laboratories, following verification of all the paperwork to ensure that they are engaged under the scheme for a longer period. So in terms of the way forward, so from the inception, this program was sort of spearheaded by the CGTB office with support from PATH. So this is part of the annual action plan and approved by the National Urban Health Mission under the innovations head. So the funding is available under the NTP and the activity is going forward. So we don't have official figures available to share, but a few thousands of beneficiaries have been benefited in the past year, and the program is running successfully. So in terms of next steps, so evaluation of the scheme to incorporating the modifications in scope or contract rate would have to be undertaken. So thanks everyone for patient hearing. I will take questions. Over.
Yes. Thank you, Dr. Deepak, for presenting the model. Now it is Q&A session. Participants, if you have any questions, please feel free to ask. Unmute your mic and please come in. I don't see any questions in the... There is a question. Yes, there is a question from Dr. Shilpa. It's a feedback for PATH South Asia. Would you like to come in? Dr. Shilpa, please unmute your mic.
Yeah, I just wanted to comment briefly on the pictures used in the presentation. I think it'll be great if we can use pictures representative of the population that has been served. I thought that was a miss. And Mumbai has wards, not districts. I think that's what he was referring to. Correct me if I'm wrong, Dr. Deepak.
Agreed. Under NTP, we have districts. So the wards are aligned with the districts.
Okay.
We have a city, state level structure, a city structure, which is unique for Mumbai, and it has NTP districts. So for NTP, it is districts, which is wards for the...
For Mumbai city. Okay. Thanks.
Okay, thank you. Are there any other questions? Okay. I don't see any questions, but I do have one question for both the speakers, Dr. Smriti and Dr. Deepak. We are constantly talking about incentives for private sector engagement, especially Smriti, you were talking about it was very difficult, especially for physician assistants. In general, what kind of incentives would work for private sector engagement? Is it always financial incentives, or in your experience with the implementation of these models, what would work best for long-term sustainability of value-based private sector engagement?
Yeah, thanks, Dr. Meena, for that question. How these programs are implemented, they're often very short term, and incentive is the way to go in that case. But we did realize that doctors also value the outcome of the patients they are engaging with. So bringing the doctor on your side, talking about the kind of lab facilities the patient support that either the state TB program or any private partner who is implementing the program in that particular area, convincing the doctor that that is something that would lead to well-being of the patient is what worked for us, even in the absence of incentives. And also just talking about different aspects of TB care and how much investment is going in it, and various priorities of the government, and how a particular doctor in a particular area can contribute to those things did help us in keeping the physicians on our side. Regarding engaging physician assistants who would be doing a lot of work, we also felt that a lot of the data collection was a bit redundant, and it was too much of an expectation from the doctor's office to collect all the data, keep updating it on the NextShare portal and all that. So maybe streamlining the process, keeping the details to a minimum. The government is moving heavily towards an universal identification number. So maybe utilizing that to streamline all the data collection process such that it's not a very operations and heavy process, and the doctor can easily do it via just one number would be very helpful. So physician assistants, if the doctor is on your side, the physician assistants would support you. But still they do expect incentive sometimes, but I think the other things I suggested would help bringing the physician assistant on your side as well. Thank you.
Yeah, thank you, Dr. Smriti. Dr. Deepak, you have any thoughts on this?
Yeah, maybe I just quickly add on. So as I think Smriti mentioned on the incentives. So what we observed in Mumbai also is that identification and empaneling these private facilities indirectly also increases the footfall of the beneficiaries. So these beneficiaries act as other tests in those facilities. So it's sort of an indirect fund flow for these facilities also, in addition to the reimbursement for the test which the program is providing. So it serves as a carrot approach to improve the engagement. Over.
Yeah, thanks, Dr. Deepak. Thanks for your responses. Since we have some time, I would like to take the question of Vinod. Vinod, if you're there, can you please come in with your question to Dr. Arsha?
Yeah, basically, I just want to know what was the mechanism for contracting with the courier partner in their model e-pharmacy model, whether it's distance based or it was done based on the services provided, or specific volume was provided for the contracting. A brief idea, not very detailed, just a snapshot of that. Yeah, thank you.
Sure. So yes, it was a deliverable based contract. So, the partner was paid per the service provided, so per patient basis. That was the arrangement that we had under Samagra.
Okay, no criteria of the distance as well.
No, we were covering the entire city of Indore, outskirts of Indore, just the peri-urban areas, but we did not include rural areas. So the entire city of Indore was included, and there was no cap in terms of distance traveled.
Okay, thank you. Thank you so much.
Thank you.
Thank you. So there is one small question to Dr. Deepak. Is there any information on the eligibility criteria for patients to receive these free diagnostic services through vouchers? This is a question from Mohana.
Yeah, so all those beneficiaries who are presumed to have triple TB were eligible, and in case there was a nearby public facility which had those services provided, then they were linked to the public facility. But especially requiring higher investigations like CT guided biopsy, etc., so they were referred to the facilities. So anyone suspected with EPTB and unable to access the services were eligible.
Thank you, Dr. Deepak. So with all those presentations, we have come to the end of the roadshow. I think today we have learned about 4 promising models for engaging private healthcare providers in TB service delivery. The first model, where Dr. Akshi spoke about the use of gene experts in diagnosing TB among the pediatric population. The second model was presented by Dr. Arsha on e-pharmacy, where anti-TB drugs were delivered at the doorsteps of persons with TB. Dr. Smriti illustrated the Stop TB Reach Wave 7 model for case finding and treatment, which is founded upon building relationships and networks with private healthcare providers. And finally, Dr. Deepak presented us the extrapulmonary TB scheme. I hope these models have inspired all of you, and you are already thinking about how to contextualize these models to replicate in your own settings. I'm very happy about that. I'm certain that you all had rich learnings and this learning will continue. We are planning to hold next series of roadshow in the last week of May. So watch out for notification from our end. I now pass the mic to Dr. Mohana, Community Manager, TBPPM Learning Network, to give the vote of thanks. Thank you.
Thank you everyone for your active participation in today's virtual roadshow on public-private TB care service delivery models in India. We had an insightful session with valuable presentation and discussion. As we conclude, I would like to extend our sincere gratitude to our esteemed speakers, um, moderator Meena, Dr. Ramya, and audience for making this event a success. I encourage you all to stay engaged with the TBPPM Learning Network and take advantage of the resources and opportunities it offers. The sessions recordings will be available on the YouTube channel, which I'll be posting it in the chat box. Those who may be missed out any points or would like to revisit the discussion forum, in the coming days, we will be sharing a detailed report. I'll be emailing the report to each one of you who have registered today's discussion, and keep an eye for the updates on our website and social media channels. Once again, thank you for joining us today. Your active participation and contribution are instrumental in advancing the TB control efforts in India. Let's continue working together to end the TB by 2025. Have a great day. Thank you.